Myself, Dr. JIBRAN presents to you Simply Pathology, and today we are back with very important lecture. Today we are going to start the series of WHO updates. So today we are going to understand about the updates in the hematolymphoid neoplasms, the 5th edition. Although the WHO 5th edition is not out, but the updates have been out, and today we are going to start a series of updates in the hematolymphoid system. So today we are going to discuss the part 1 of the updates. Mainly we are going to discuss the myeloproliferative neoplasm, the introduction of clonal hematopoiesis as a definitive entity, and we are going to discuss about mastocytosis as well. So without wasting any time, let us begin today's topic of discussion. So as we can see that the basic funda or the basic way in which we are actually diagnosing any kind of hematolymphoid neoplasm is the same as in the previous edition, wherein we are using lineage, attribute, clinical attribute and biological attribute for diagnosing a particular condition. So what does lineage attribute means? It means the one which is resting on immunophenotyping and flow cytometry and or immunohistochemistry. So when we are using these investigations, okay, for assigning a particular lineage, okay, to a particular tumor. Clinical attributes meaning whether it is an acute, chronic, or what are the cytopenias that we can see if dysplasia is present, myelodysplasia is present, or cytosis or myeloproliferation is present. Then we are having biological entities like all the different kinds of cytogenetic entities like the genetic fusions, rearrangements, or any kind of mutations that we see. So basically a deliberate attempt, just like in the previous edition, okay, it is made to prioritize the classifying of the tumor types based on the defining genetic abnormality where it is possible. And this is the same across all the WHO blue books, whether it be your CNS or soft tissue tumors or be any other entity or renal tumors or any other tumors. So we are trying to go more towards the molecular aspect. Okay. So the emerging entities, whatever we are seeing, they are listed as the disease subtypes. Okay. And very important thing that we have to understand, this application of this the new classification system, it is based on integration of the morphologic, immunophenotypic, molecular and cytogenetic data. So this is in line with the previous edition. So the 5th edition is in line with the previous edition in the basic aspects. Okay. So what are the most important changes we are going to see? Now, although we have heard about the term clonal hematopoiesis before, but in this edition, the WHO has formally introduced the clonal hematopoiesis as one of the precursors of the myeloid neoplasms. Okay, so let us first understand what we mean by the term clonal hematopoiesis. It is broadly referring to a population of cell which is derived from a mutated progenitor cell or a multipotent stem cell which is harboring a selective growth advantage in the absence of any clinical features, like there is no cytopenias, no hematological cancers or any other disorder that is not present. So try to understand what is the meaning of clonal hematopoiesis. It is just meaning that among the group of stem cells in the bone marrow or certain progenitor cells in the bone marrow that is present, some group of the stem cells are having an added advantage, okay, that they are showing a more growth as compared to the other stem cells. Okay, and such kind of growth advantage or such kind of increased growth is not accompanied by any of the clinical sign symptoms. Means there is no cytopenias, no cancer association, no clonal disorder association. The incidence of clonal hematopoiesis is increasing with the age, and what is very significant about clonal hematopoiesis, there is an increased overall mortality associated with clonal hematopoiesis, increased incidence of cardiovascular disease as well as myeloid malignancies. Not only that, they have also seen that there is an interplay or there is some connection between inflammation and clonal hematopoiesis as well as myeloid neoplasia. Okay, and such kind of association is now being gradually discovered over a period of time. Okay, so now the clonal hematopoiesis in this classification, it by including them, there is an effort, okay, to codify such myeloid precursor lesions, meaning that they are regarding the presence of clonal hematopoiesis as a precursor to any myeloid lesion. So the basic importance is if clonal hematopoiesis is there, you can become quite alert. You can start the treatment and you can search for the condition. Okay, so there can be increased surveillance that can be put into the picture. So this is basic what is clonal hematopoiesis. So there are certain terms. What is CHIP? So before you must have heard about this term CHIP while we were reading myelodysplasia syndrome, but now it has been introduced. So what is it? It is basically referring to a clonal hematopoiesis that is harboring some kind of somatic mutation. Okay, mutation of which genes? Those genes which are unusual associated with a myeloid disorder or a myeloid malignancy. Okay, and which is detected, such mutations being detected in the blood or in the bone marrow at a VAF. VAF stands for variant allele fraction of more than 2%. In individuals who are not having any sign symptom, like there is no diagnosed cytopenias or no diagnosed hematological disorder or no any unexplained cytopenia. So as we have seen, what is clonal hematopoiesis of indeterminate potential? It is defined as a term referring to clonal hematopoiesis taking place, clonal hematopoiesis which is occurring because of some kind of mutation in those genes which are associated with myeloid neoplasia, and where is such mutation present? In the blood and the bone marrow, giving certain added advantage to these stem cells or to these progenitor cells. Okay, and it is in absence of any sign symptoms or clinical sign symptoms, so there is no diagnosed hematological disorder or unexplained cytopenia. Now this is one term. Another term over here that has been formally introduced, that is the CCUS, that is clonal cytopenia of undetermined significance, which is defined as CHIP, which is detected in the presence of one or more persistent cytopenias that are otherwise unexplained by hematological or non-hematological condition, and they do not meet the diagnostic criteria of any defined myeloid neoplasm. So clonal cytopenia of undetermined significance, over here you are having CHIP, but along with CHIP you are having some unexplained cytopenias is there that cannot be explained by the presence of any other hematological or non-hematological neoplasm. So this is something that you have to understand. Okay, now very important thing that in the new edition the cytopenia definition for certain entities have been harmonized. So for some entities like CCUS or MDS or MDS-MPN, so in these conditions whenever you are speaking about cytopenia, that means in case of males hemoglobin is less than 13, in females it is less than 12 gram per deciliter. For anemia, so absolute neutrophil count, so the cutoff level is 1800 cells per cubic millimeter. For leukopenia and for platelet count less than 1.5 lakhs per cubic millimeter is regarded as a thrombocytopenia. So this has been given, and these terms are formally introduced. What is CHIP? What is CCUS? What are cytopenias in case of CCUS, MDS, MPN? Okay. So in summary is the clonal hematopoiesis is recognized as a category of a precursor myeloid disease state. This wasn't there before, but now it has been formally defined. Okay. Then CHIP and CCUS have been formally defined, and lastly cytopenias cutoff has been given for these above conditions, including for MDS, MPN. Now in today's topic of discussion, we are also going to include the myeloproliferative neoplasms and what are the changes that have been introduced in the myeloproliferative neoplasm. So this was the definition that was given for myeloproliferative neoplasm in the 4th edition of WHO. As you can see, there is a CML, BCR, ABL positive, CNL is there, polycythemia vera, primary myelofibrosis, essential thrombocythemia, chronic eosinophilic leukemia, NOS was there, and myeloproliferative neoplasm unclassifiable was there. So this was the initial 4th edition definition. So what are the differences that we are now using over here? So in this case, if you see, very important, if you look at the classification, all the entities are same except, okay, they have introduced a new entity called as JMML into the classification of myeloproliferative neoplasm. Now remember, previously JMML was under the the umbrella of myeloproliferative MPN, MDS. Okay, they were under the umbrella of this particular condition, but now it has been seen that there is no dysplasia, and 90% of the cases of JMML, they are showing increase in RAS activation, so they are myeloproliferative in nature. So the move has come to place the JMML under the myeloproliferative category. So this wasn't there. This is the number one difference that we see. The number two things, if you see, the main changes under the myeloproliferative neoplasm is in relation with the CML. In CML, if you know, there were 3 phases before. Okay, so one is your chronic phase, accelerated phase and blast phase. So today, if you go back and see, they have removed the accelerated phase now. Okay, in polycythemia vera, in the major category, in the major criterion, there are certain changes in the diagnostic criteria. Not that much, but there are certain changes. The diagnostic criteria for diagnosis of the chronic eosinophilic leukemia has been completely changed, and we will discuss what are the criteria now. Okay, and very importantly, before they used to use chronic eosinophilic leukemia NOS, but now because the criteria has been characterized very well, so NOS has been removed now. Okay, even myeloproliferative neoplasm unclassifiable was used before, but now we are using NOS at this point of time. Okay, so let us begin today's topic of discussion. So as we have already discussed, okay, that how we are going to, how we are basically identifying, and whatever points I have discussed over here is written over here, so we are not seeing. So the first entity, that is the CML. So the risk factors have been refined. Accelerated phase over here is no longer required. So there is no longer accelerated phase that is required over here. Very importantly, the CML is defined by the presence of BCR ABL1 fusion that has already been there. Now, whatever I have highlighted in red, that is the new changes. Okay, whereas the rest of the changes are same. So CML again is defined by the presence of BCR ABL fusion, and there is translocation 922 over here as we see. Now, as we have seen the natural history of untreated CML, they will have biphasic or triphasic. Either they will have, so the indolent CP phase is there, that may or that will progress to blast, and in between they may or may not have accelerated phase. Okay, so with the introduction of the tyrosine kinase therapy and careful disease monitoring, the progression to the advanced phase has decreased, and the 10-year overall survival for CML is 80 to 90%. Okay, now the designation of accelerated phase has become less relevant in case of CML. Why? Over here the resistance is stemming from the ABL1 kinase mutations and or additional cytogenetic abnormalities. Okay, and development of blast phase represent the key disease attribute. So what is very important, okay, that why it is of no use to label it as an AP phase, because there is a resistance which is occurring mainly because of ABL1 kinase mutations. Okay, there are certain mutations or added cytogenetic abnormalities that are taking place. Okay, so that is basically responsible for the resistance. Okay, that is responsible. So it is important to recognize those particular things. And the second thing is that the development of blast phase is something which is important. So these are something key areas. Once they are developing some kind of resistance to therapy because of development of mutations or cytogenetic abnormalities, or there is development of blast phase. So once these things are there, then AP phase doesn't become that much relevant. So AP is omitted in the current classification in favor of emphasizing on high risk features associated with the chronic phase progression and resistance to TKI. So if your patient is showing a resistance to tyrosine kinase inhibitor, okay, so this is far more important than considering the AP phase. Okay, so the criteria for the blast phase is same as before, but there has been an addition over here. So as before, the criteria for blast phase is having more than equal to 20% myeloid blast in the blood and bone marrow. Number two, the presence of extramedullary proliferation of the blast. So outside the bone marrow, if you see that there is a proliferation of blast in some areas, then that is also a criteria for the blast phase. Now, very importantly, the third thing that has been new over here is the presence of increased lymphoblast in the peripheral blood or bone marrow as a criteria for the blast phase. Now, lymphoblast in CML in the peripheral blood or bone marrow. Now, as such, there is no such percentage or cutoff has been given that how much percentage of lymphoblast should be there. Okay, so this becomes very important new entity, and this should be included. So what is very important is the blast phase as such is important. The development of resistance to TKI with the with the development of ABL1 kinase mutations or additional cytogenetic abnormalities. So more stress has to be laid out to do cytogenetic on molecular studies to detect these resistance to therapy, to detect these new mutations or these new cytogenetic abnormalities that has led to resistance to therapy. That becomes more important than defining the accelerated phase. That is why that is not being used as of this point. Okay. Now, very important thing is now minor changes is there in the diagnosis or criteria for BCL, ABL negative myeloproliferative, like the PV, ET, MF, CEL, CNL. Okay, all these things, they have minor changes, but they are there. So just like before, how we used to have criteria for the PV, ET, PMF, that is there over here. Okay, so let us look over here. So what I want to tell you over here, I'm just going to tell you the differences. I'm not going to enlist all the diagnostic criteria. You might go through them, but relevant diagnostic criteria will be discussed only in the relevant topics when they are being taught. But over here, we are just going to see the differences. So the diagnostic criteria of PV more or less is the same. The only thing is the increased RBC red cell mass. Okay, this was there in one of the major criterias as an OR, but this criteria has no more relevance because this test, if you see, this test used to be carried out. Okay, the polycythemia vera test, the determination of RBC cell mass was carried out with 51 chromium labeled red cells. It has become uncommon use in the clinical practice, and that therefore it has been removed as a diagnostic criterion. Rest all the things, all the criteria for polycythemia vera remains the same. Okay, this point you have to remember. Okay, now we come to the diagnostic criteria for essential thrombocythemia. Whatever was given in the 4th edition, it is the same. No changes as such has been made over here in the diagnostic criteria for the ET, as well as for the myelofibrosis, the pre-fibrotic, as well as the overt fibrotic stage. I'm not discussing individual criteria over here because that will be discussed in the individual topics, but these more or less they are same. So ET, the criteria have same. Now for primary myelofibrosis, basically what is primary myelofibrosis? What happens over there? There is a proliferation of abnormal megakaryocytes, okay, and granulocytes in the bone marrow, and they are associated with fibrosis. Okay, fibrotic stages with a polyclonal increase in the fibroblast, which is driving reticulin and collagen marrow fibrosis, osteosclerosis, and extramedullary hematopoiesis. This is nothing new. All these were already there in the 4th edition. I'm just repeating them. Okay, so what is the importance? Okay, it is importance. Remember, any kind of myeloproliferative neoplasm, okay, they can progress to the pre-fibrotic PMF, and ultimately they can be overt primary myelofibrosis. So what is very important is to recognize this stage. Okay, why to recognize this stage? We have to see whether any MPN is progressing towards this stage or not. So recognizing the pre-fibrotic PMF remains necessary to separate it not only from the MPNs but also from fibrotic variety. The importance, so how do we do it? By monitoring the bone marrow fibrosis and the spleen size, because more will be the fibrosis, okay, more will be the spleen size. Leukoerythroblastosis will become more. Okay, now PVET, these are the MPNs, they progress to the accelerated phase or the blast phase in very minority of the cases, but leukemic transformation is more frequent in the primary myelofibrosis stage, and leukemia-free survival is shorter in the fibrotic stage than pre-fibrotic. So if a person goes into pre-fibrotic stage of PMF, okay, then the lookout for the patient is better as compared to those patients who are in the PMF. Again, this is same as it was there in the 4th edition. No new changes is there. Again, these are certain changes in association with the different kinds of MPN. With JAK2 CALR MPN mutations are considered the major, or they are considered as the driver mutation. Driver is the most important mutation which is driving the particular neoplasia, okay, particularly in other genes, and mutations in other genes like TET2, AXS12, DNM2, they are found in over half of patients with MPN. So as we have seen, we are reading about the MPN. So if you see in the diagnostic criteria of the overt fibrotic stage also, they have used these markers, okay. In case of early or pre-fibrotic stage, they have also used them. So in case of over here ET, as well as in case of your PV, polycythemia vera also, they are using this main mutation. So they are the major driver mutations, and other mutations, for example, that in the TET2, ASXL1 and DMT-T3A, they are found in 50% of the patients of MPN. Now there are some other mutations which are seen in the myeloproliferative neoplasms. So mutations affecting the splicing regulators or epigenetic functions or cellular signaling. These include SRSF2, SF3BB1, UTAF1, ZRS2, or for example IDH1 to CBL, KROS, NROS. All these, they are less common. So it is prudent that you remember these mutations more importantly in case of myeloproliferative neoplasm. Now additional mutations or these extra mutations that you see, they are more frequent in primary myelofibrosis and in case of advanced disease as compared to the PVET. Okay, and some are known to correlate with the poor prognostic factors as these uncommon mutations as we have seen. Okay, so with this we have completed more or less about the PMF or as well as the PVET and PMF as a whole, and what are the basic things. So these are same as compared to in the 4th edition. Now, even if you look at the criteria of the CNL, that is chronic neutrophilic leukemia, everything is same. So I'm not going to discuss each and everything. You can go back and see. Persistent count, neutrophilic count more than 25,000, 80% should be segmented neutrophils. Along with that, the band cell should be there. Then bone marrow hypercellularity should be there because of neutrophilic granulocyte proliferation. Hepatomegaly is that they have CSF3R mutation is very common and seen in 60% of the cases. So the same criteria that was there before is same for case of CNL. Now, the major changes over here come with the chronic eosinophilic leukemia, wherein there are major changes that has been there. So, the chronic eosinophilic leukemia, if you remember, it is a multi-system disorder characterized by sustained clonal proliferation of morphologically abnormal eosinophils as well as eosinophil precursors, resulting in persistent hypereosinophilia. Now, several changes are there to the diagnostic criteria of CL if you compare before and now. The time interval required to define sustained hypereosinophilia, it has been reduced from 6 months to 4 weeks. Very important. Secondly, addition of requirement for both clonality as well as abnormal bone marrow morphology. Okay, that is there. So not only the clonality, so along with clonality, so before there was clonality may or may not be there, but today clonality has to be there. And abnormal bone marrow morphology, both of them has to be present for the definition of CEL. And there was one criteria that was alternative to clonality that has been eliminated. So increased blast, that is more than 2% in peripheral and or 5 to 90% in the bone marrow. So this criteria has now been removed. So I will just show you over here. So all the eosinophilia, initially there was for 6 months, but now they say that even if it is there for 4 weeks, we are going to consider and take this criteria. Okay. Now there should not be any rearrangement of these genes, because this, if present, then they come under separate heading of WHO neoplasms. Okay. Now over here again, blast should be less than 20%. That criteria is there. WHO criteria of other myeloproliferative neoplasms should not be there. Very important. This clonal cytogenetic, this or this, that is there. This should, you have to prove clonality. Before, this was there as an alternative. This is no longer there. You have to prove that it is clonal in nature. That is very important. Okay. Okay. Now one other thing that is there, previously they were using this term NOS, but now they are not using this term NOS. This has been removed from there. Why? Because criteria have been very well defined now for chronic eosinophilic leukemia. Okay. Okay. Now, as in other conditions, very important that you should understand that in the prior editions you were using MPN unclassifiable, but now you are using the designation MPN NOS. Okay, that is very important. And for which you are using this MPN NOS, it is used for those conditions wherein you cannot group the disorders, okay, which are reserved for cases who are having the clinical, laboratory, morphological and molecular features of any MPN, but they are lacking the diagnostic criteria of any specific MPN type. So they are basically kept under the MPN NOS. Before it was MPN unclassifiable, we are now using the term MPN NOS. Now, as we told you that JMML is now not under MDS MPN. No dysplasia has been seen over there. Now, mostly myeloproliferative or RAS mutations are more common in JMML now. Okay, so let us see. It is a hematopoietic stem cell derived myeloproliferative neoplasm of early childhood. The pathogenetic mechanism in at least 90% of the cases involves unchecked activation of the RAS pathway. RAS pathway means excessive proliferation will be there. So myeloproliferation will be more with this. So what are the updates to diagnostic criteria? There is exclusion of KMT2A rearrangement. Elimination of monosomy 7 as a cytogenetic criteria, emphasizing the significance of diagnostic molecular studies, particularly those aimed at demonstrating the RAS pathway activation. So myelodysplasia is not there. So why to keep under MDS MPN? So they are, out of the MDS MPN category. Okay. So remember, this category is no more there. Okay. Monosomy 7 category is no more there. Okay. Okay. Now the summary box, okay, of all the changes that we are looking in case of myeloproliferative neoplasm, CML phases have been consolidated into chronic and blast phases. No AP phases there. In fact, more importance is there on recognizing the resistance to tyrosine kinase inhibitor therapy. Okay, so we have to detect the mutations as well as the cytogenetic alteration that is leading to resistance to therapy. That is more important as compared to recognizing the AP phase. The diagnostic criteria of CEL, chronic eosinophilic leukemia, has been updated and the qualifier NOS. So CEL NOS is no longer used now. GMML it has been placed under myeloproliferative and it is not under MP and MDS category now. And in the PV, the criteria of RBC mass has been now removed because this testing is not being done anymore. Okay, very important. So these are the important changes that we have seen in case of myeloproliferative neoplasm. Okay. So now we are going to read about the mastocytosis and what are the changes that has been under this heading. So as we know already, mastocytosis is nothing but this is a rare heterogeneous neoplasm characterized by accumulation of abnormal mast cells in various genes and organs and tissues, typically driven by constitutional activation of the KIT receptor. There are three important classes just like the fourth edition, that is there is systemic mastocytosis, cutaneous mastocytosis, and there we are having mast cell sarcoma as well. So these three important disease types are being defined as it was there previously, it is there now only. A somatic point mutation in the KIT gene and the codon 816 is detected in more than 90% patients with your systemic mastocytosis, just like in the previous edition, this is also same. But what is very important, the diagnostic criteria for systemic mastocytosis have been modified. Namely, the expression of CD30 and the presence of any KIT mutation have been accepted as a minor diagnostic criteria. Okay, remember this, basal tryptase level more than 20 nanogram per ml is still a minor criteria for systemic mastocytosis. If I show you this diagram, the diagnostic category criteria for the cutaneous and this, if you see, so basically if you see in the minor criteria there has been two addition. Okay, so this is the systemic mastocytosis criteria that we are seeing. So under the minor criteria there have been addition of expression of CD30 as well as presence of any kind of KIT mutation has been accepted as a minor diagnostic criteria. And serum basal tryptase level of more than 20 nanogram, it is still a minor criterion and it is stored over there. So this is one of the major thing that has been changed and new thing has been introduced. Not only that, if you see, if you look at the classification over here, the major classifications are the same. Okay, for cutaneous mastocytosis, the same entity, but over here in systemic mastocytosis, the new entity has been introduced, that is a bone marrow mastocytosis has been introduced now. This is the new entity that wasn't there previously. This has been introduced over here, bone marrow mastocytosis. So in addition, the bone marrow mastocytosis is now a separate subtype of SM, which is characterized by the absence of skin lesions and B findings and a basal serum tryptase level below 125 nanogram per ml. Okay, now what are the classical B findings and C findings? So how do you define classical B findings? So KIT point mutation at the location 816V with a variant allele fraction of more than 10% in the bone marrow cells and peripheral blood leukocyte qualifies as B finding. So remember, this has been well defined over here in this particular condition. So the summary of changes that we see in mastocytosis, if you are going to see the diagnostic criteria for mastocytosis have been modified. For systemic mastocytosis, the CD30 and any KIT mutation is introduced as the minor criterion. Bone marrow mastocytosis have been introduced as a new systemic mastocytosis subtype, and KIT 816V mutation with a fraction of more than 10% qualifies as a B finding. So with this we have completed the part 1, and if you want to enjoy part 2 and 3 updates and the remaining updates that is there for the myeloproliferative neoplasm, you are kindly directed towards our website simplypathology.teachmore.com. The link of that has been given in the description box. Thank you very much for watching this particular video.